It is my pleasure to welcome you to Pediatric Grand Rounds today. My name is Elizabeth Donner. I'm the director of the Comprehensive Epilepsy Program here at Sick Kids within the Division of Neurology. I would just like to start with a land acknowledgement and acknowledging the land on which Sick Kids operates. For thousands of years, it has been the traditional land of the Huron-Wendat and Penton First Nations, the Seneca, and most recently the Mississaugas of the Credit River. Today, Toronto is home to Indigenous peoples from across Turtle Island. Sick Kids is committed to working towards new relationships that include First Nations, Inuit, and Métis people, and is grateful for the opportunity to share this land in caring for children and their families. And now it is my absolute pleasure to introduce Dr. Carter Snead. Carter is both a mentor and a friend to me, and I'm so pleased that he will be sharing his experiences with us today. Dr. Snead received his BSc and MD from the University of West Virginia and then trained in pediatrics at Duke, and then child neurology at Yale. This was followed by a 2-year stint in the United States Air Force, and he has held academic positions first at the University of Alabama, and he was head of child neurology at USC before he joined the Sick Kids as the head of the Division of Neurology from 1996 to 2012. He's currently staff neurologist and clinician scientist in the Division of Neurology and a senior scientist in the Research Institute. As most of you know, Dr. Snead's major clinical and research interest has been in pediatric epilepsy. He developed our epilepsy surgery program and has pioneered work in animal models of epilepsy. He has received countless awards, including designation as the founder of child neurology by the Child Neurology Society and the International Child Neurology Association. I could go on, but he asked me not to. So I will allow him to start. I'm excited that today Dr. Snead is going to tell you about his work to transform epilepsy care for tens of thousands of infants, children, and adults in Ontario over the last 8 years. Carter? Just ask you to share your screen.
Good morning, everyone. So everyone in this audience who cares for patients in any capacity is a storyteller. We constantly tell each other patient-related stories to which we listen and embellish. So my story today concerns a remarkable effort that we've made over the years to break down the barriers between the ivory tower and the community of practice. And specifically, I want to describe the end-to-end system of comprehensive epilepsy in Ontario. And my slides are advancing automatically and they're not supposed to. So I want to just want to cover some basic terms now so we're all on the same page. A seizure is an episodic behavioral event which is caused by a paroxysmal discharge of neuronal circuitry. Epilepsy simply refers to spontaneous recurrent seizures, and EEG, about which you'll hear a lot, represents a recording, usually from the scalp, of the electrical field activity of hundreds of millions of cortical neurons from scalp electrodes. Our story started in the late 1990s when our group, headed by Hiroshi Atsubo, was conducting pioneering work looking at a unique technology to identify non-invasively the epileptic focus in children who were undergoing evaluation for epilepsy surgery. This technique is called MEG, and it's based on fundamental principle of physics 101, and that is that anything that generates an electrical current generates a magnetic field around the current. And therefore, every nerve cell, every one of the 200 million nerve cells in your head is generating an electrical current from cell to cell and generates a magnetic field around that current. And MEG is a way to look at and measure the magnetic activity produced by the electrical current of neuronal networks of the brain. So we did that. We started out in the late 1990s using MEG, and it was all self-funded by Sick Kids. They bought the equipment, they maintained it. It was very expensive. And in light of repeated requests from us for funding, the Ontario Ministry of Health conducted a study in 2008 asking the question about the value of neuroimaging in the pre-surgical evaluation of epilepsy surgery candidates, specifically MEG. So what happened was that I'm sorry, I'm not sure what to do about this because the slides keep advancing without me advancing them, and it's not going to screw me up. Okay, I'll try it again. So basically, they conducted a study that they organized by, they commissioned the PATH group, the Program of Assessment, Technology and Health at Master, to conduct an extensive retrospective study of epilepsy surgery at sick kids. And they followed all our patients over a 2-year period, starting from the time the child was referred with the question of, is this child a candidate for epilepsy surgery, all the way through all the case conferences and the surgery and they looked at the outcome. And they case costed everything. And the way things worked then in 2011 was that if one had a new diagnostic procedure or medical or surgical treatment, and you were seeking funding for it from the Ministry of Health, you had to show that it worked. You had to produce objective evidence that what you were proposing worked. And then you presented that evidence to a group called the Ontario Health and Technology Committee, or OTAC. And then if OTAC evaluated the evidence and decided that yes, this was effective, the next step would be to ask the question, is it cost effective? And then the data would be presented to Health Quality Ontario. And if Health Quality Ontario felt that yes, the procedure that you're asking about is effective and it's cost effective, then the whole project would go to the Ministry of Health, who would evaluate it in the context of their priorities at that time. So this is the process that we went through with MEG. That was what we were asking for. What's the value of MEG in epilepsy surgery, and will the ministry fund MEG in epilepsy surgery? And so what happened was we presented our data to the Ontario, to OTAC, and we basically gave them a primer on epilepsy. So we pointed out it's one of the most common neurological diseases in Ontario. The prevalence is, as you see. At that time, there were 95,000 patients in Ontario who had epilepsy, of whom 80,000 were adults. And now there's probably way more than that, and because this is in 2011. So there are now, so we point out there were 95,000 Ontarians with epilepsy, and a third of these patients have drug-resistant epilepsy, that is, epilepsy that doesn't respond to medication. And this is typical throughout the world. Virtually every series shows about a third of patients who have epilepsy have seizures that just don't respond to medication. And of these, we estimated 20,000 might be potential candidates for epilepsy surgery based on the features of their seizures, whether they had a lesion, et cetera. However, in the time we looked at, only 750 patients had epilepsy surgery in Ontario. So during this study and our presentation of the data to OTAC, we answered the question that yes, MEG is useful in epilepsy surgery and non-invasively identifying children who might be candidates for surgery itself. And the study led to really interesting papers that we presented validating that yes, it worked. But an unforeseen consequence happened from our presentation. We presented this asking for funding for MEG. That was the bottom line. But OTAC basically focused on the fact that so few patients who had epilepsy surgery received it in Ontario. And they said, why was this? How come so few patients have access to surgery, and what can we do about it? And they struck an expert panel on the spot that day to bring back answers to this question. And so a number of us, epilepsy providers, stakeholders, pediatric and adult neurologists, pediatric and adult neurosurgeons, came together and put together an answer to this question and a potential solution. And we were aided in this by Tawfiq Valiente, a neurosurgeon at UHN, who had thought about this for some time. One of the big things that we came up with in terms of barriers to epilepsy surgery were the attitudes and awareness of primary care providers, pediatricians, community neurologists concerning really a lack of understanding of what the indications of epilepsy surgery are, where its role in curing epilepsy, and who should get it. Another big issue at that time was the care in Ontario for patients who had epilepsy, both adults and children, was very disorganized and limited. And really, the quality of care that you got depended on where in the province you lived and who happened to be taking care of you. And this is a challenge everybody in Ontario who's seeking to provide some kind of program of care for a cohort of patients faces. And that's the enormous difficulty delivering equitable care to patients in the North, where care is really difficult to access. So when we came back and presented our recommendations, we pointed out to OTAC exactly what happened now. So the patient has the first seizure, they go to the ER, and then they're sent home with or without treatment. They may have a second seizure, they go back to the emergency room, and then they may or may not make it to a primary care provider, and their treatment may or may not be effective. And what happens is many of them, particularly in remote and rural areas, seizures are uncontrolled because of a lack of knowledge of how to control seizures. And these patients wander in the wilderness for years, and their lives are just progressively destroyed by their uncontrolled epilepsy. So the expert panel issued a report, and we proposed a system of regionalized epilepsy care in Ontario to address the need with the following caveats. We pointed out that this strategy has to apply to everyone, that you can't devise a comprehensive epilepsy strategy focused only on patients who are candidates for epilepsy surgery, because that's a small sliver of patients. And so you really have to take care of everybody to get to those patients, and also to take care of the patients who have bad epilepsy, who are not candidates for surgery, but in whom other non-surgical treatments may work. The second thing is, I'm a pediatric neurologist. This was presented from a pediatric hospital in a pediatric epilepsy series, but any comprehensive epilepsy strategy had to apply across the lifespan, and we were very firm about that, and OTAC got it. And finally, the underlying principle, the driving principle of this whole project was that epilepsy surgery should always be done in a timely way and should never, ever be considered a treatment of last resort. So what we proposed was a regionalized system of epilepsy care, where there would be epilepsy centers throughout the province, which would serve as community resources for patients who had epilepsy and for their primary care providers who were taking care of them. So we proposed a district epilepsy center, which would be a resource for everyone. And the purpose of these district epilepsy centers would be to provide a comprehensive epilepsy program, which has all the features that you see there. And they would be able to provide assistance and consultation to community neurologists and primary care doctors and pediatricians who took care of patients with epilepsy, and take care of complex patients, and do preliminary evaluation preliminary surgical evaluation for those candidates who may be candidates for epilepsy surgery. And by that, I mean they could do the imaging, the 3T MRI, they can do the neuropsychological evaluation, the careful pre-surgical medical and neurological evaluation, and the EEG video monitoring and epilepsy monitoring unit, which is the first step that one does in epilepsy surgery evaluation. And all of that could be done in one place. And then if a patient was thought to be an epilepsy surgery candidate, then they'd be referred to another group of centers throughout the province where epilepsy surgery was done, the Regional Epilepsy Surgery Centers of Excellence. These centers would serve as a district epilepsy center for their catchment area. They would evaluate all the referrals from the district centers for epilepsy surgery. They would have the comprehensive epilepsy program resources that I showed you before, in addition to all of the sophisticated neuroimaging that we need to really carefully evaluate the candidacy of anyone for epilepsy surgery. And they have the capability, state-of-the-art capability for any kind of epilepsy surgery that might be indicated. So now what we proposed was that a patient had a seizure, an epilepsy diagnosis would be made, And then primary care, they would be seen by their physician. And if they needed help, they would be referred to the District Epilepsy Care Center. Now, a really important component of these centers, both the district centers and the surgery centers, is that they are connected with community epilepsy agencies. And these people are vital for education, advocacy, and support for patients with epilepsy. And the district epilepsy, the DEC would then make recommendations and refer the patient back to the referring doctor. But if the seizures continued to be uncontrolled, then they'd have their pre-surgical evaluation done at the Epilepsy Care Center and be referred to the Regional Surgery Center of Excellence. So this was the proposed network this was a proposal that we made in an expert panel report in the late summer of 2011. So in 2000, OTAC approved this report, and then we presented it to Health Quality Ontario, and they approved it. And then we presented the data and the plan up through several levels of the ministry. And in 2013, the Provincial Epilepsy Strategy was funded by the Ministry of Health. And they got it, they really got it, because the first thing they did was they funded 21 additional epilepsy monitoring unit beds throughout the province. They saw that one of the bottlenecks for epilepsy surgery at that time was the fact that there were so few protected epilepsy monitoring unit beds. So if you were scheduled to go into an EMU for a surgery workup and an emergency happened in that hospital, the bed would be taken away and your EMU would be canceled. But now we have protected beds. They funded the DECs and the surgery centers, as I've described, and they funded MEG. They also struck an epilepsy implementation task force to oversee and operationalize the whole provincial strategy. Our mandate was to develop standardized epilepsy diagnosis and treatment guidelines for Ontario, and to develop a knowledge translation program for epilepsy care, so that we could deliver an understanding to practitioners throughout Ontario about the provincial epilepsy strategy, and how to better care for adults and children who had epilepsy in Ontario. So this is how the Ontario Epilepsy Network was born. These are the map of where these centers are. So there are pediatric and adult district epilepsy centers in Hamilton and Ottawa. There's an adult district epilepsy center in Kingston. We are a regional epilepsy surgery at Sick Kids, and there's another pediatric epilepsy surgery center in London, at London's Health Sciences Children's, and then the adult epilepsy surgery centers in the province are at UHN and at London. Between 2014 and 2017, we produced these provincial epilepsy guidelines. The last one that we did is truly a remarkable one about transitional care for patients who have epilepsy. It was put together by Danielle Andrade at UHN and her group. So we looked at the results of the provincial strategy, comparing the numbers of 2012 to 2019, right before COVID hit us. And so in 2012, you can see the numbers, and this is the result of the implementation of the provincial epilepsy strategy. If you look at the surgery volumes in 2012, pediatric and adult, were not very high, but they've increased significantly since that time, again, in view of the implementation of the provincial epilepsy strategy. We've kind of becoming a victim of our own success here, because we're reaching the ceiling in terms of resources for epilepsy surgery, in terms of OR time and neurosurgeons. So when we started all this, these were the barriers to epilepsy surgery in Ontario that we presented to OTAC and then later on to the Ministry of Health. The availability and organization of resources, the ministry has really in ways that I've tried to explain to you. The geography is still a problem. Those of you who are alert may have noticed that when I showed you the map of the Ontario Epilepsy Network, there's nothing in the north. We tried hard to develop a district epilepsy center at Thunder Bay, but for various and sundry reasons, it didn't happen. But I still see Thunder Bay as part of our Ontario Epilepsy Network because there's a phenomenal epileptologist there named Ayman Hassan who participates with us in our network and all decision makings and all the things that I'm going to talk to you about in just a moment. The one thing that still remains a huge issue in Ontario, and I would say at the outset, this is not unique to Ontario. The poor utilization of epilepsy surgery for candidates whose epilepsy can be cured by epilepsy surgery. The poor utilization of this technique is common throughout the world. So the problem resides really with the lack of understanding amongst primary care providers, community neurologists, and the fact that patients and families are really frightened of epilepsy surgery, as anybody would be frightened of brain surgery. So family practice doctors generally are intimidated by patients with epilepsy, and they try to refer them to a neurologist whenever possible, usually. And there's a low level of knowledge and understanding among family practice doctors about epilepsy surgery and its place in the treatment of epilepsy. Unfortunately, community neurologists also, a significant number of them are not very familiar with the place of epilepsy surgery, and many of them view epilepsy surgery as a last resort. This is the view that we really try hard to counter, that epilepsy surgery is a last resort. You should think of epilepsy surgery in anybody you see who has drug-resistant epilepsy. You should always ask the question, is surgery an issue here, or are there, and then go through your head in terms of the kinds of things that might make that patient a candidate for surgery. And patients overestimate the risk of epilepsy surgery. They think it's very dangerous, and they think it should be a treatment of last resort. And many of them think that the seizures, ongoing seizures, the epilepsy that they have or that their family members have, that surgery is more dangerous than the seizure. So now I want to digress a little bit and tell you another little story. This is a storyteller doll. It was created by a very famous potter in New Mexico named Helen Cordero in the Cochiti Pueblo. And she created it in honor of her grandmother, who she says she always remembers her grandmother draped with grandchildren, relating to them stories of the Pueblo Indian heritage in New Mexico. And New Mexico is where this system of knowledge translation was born, known as Project ECHO. And this was the creator of Project ECHO, a remarkable man named Sanjeev Arora. Sanjeev is a high-powered academic gastroenterologist at the University of New Mexico in Albuquerque. Now, New Mexico is a very poor, rural, large state. There's very few resources. Most of the medical care throughout the state is delivered by primary care providers, that is family practice doctors and nurse practitioners. And Sanjeev became concerned over time, particularly in the late 90s, that the patients he was seeing at the University of New Mexico in Albuquerque, which is the only medical center, only tertiary quaternary medical center in the state, he became concerned that many of his patients were being referred to him from rural areas with being misdiagnosed or mismanaged. And once they got to see him, they still had to travel hundreds of miles each way for their weekly treatment for Hep C, and he had a long waiting list. So he started out trying to deal with this by getting in his car and driving all over New Mexico to touch base with primary care providers and to try and teach them one-on-one about how to manage hepatitis C. But this is rather labor intensive. And so what he thought about this, and he thought about how to increase the capacity of primary care providers in New Mexico to handle hepatitis C, which was a big problem in that state. So he came up with this idea, which he called Project ECHO. And ECHO stands for Extending Community Healthcare Outcomes. And basically what this was that Sanjeev created, and is so beautiful and elegant in its simplicity, is simply a case-based continuing medical education program designed for primary healthcare providers delivered through video conferencing. Now, I've given this talk before, and in the past, I've had to explain Zoom, but no more. I think everybody in the audience knows exactly what I'm talking about when I'm talking about Zoom technology. But Sanjeev pioneered Zoom technology with case-based learning. And so the way this worked was that he created what he called an expert hub team in Albuquerque, and that consisted of Sanjeev and his and a nurse practitioner, a pharmacist, and a psychiatrist. And he created a 10-week course in hepatitis C. He advertised this to these primary care providers he had personally come to know over the years over the state of New Mexico. And every week he would have a 2-hour session. And those of you who have done Zoom knows 2 hours is a long session, but they were very well attended. And the way it worked was that he would solicit case reports from his community partners, which he also calls spokes. And these were standardized, anonymized case reports that the community practitioner would create. And they would start out with the community practitioner saying, this, and this is my question. And then this, and this is the patient's question or the patient's family's concern. And then they go through a series of things tailored for hepatitis C. The case report would be presented, and then clarifying questions would be asked for by the community practitioners first, and then by the hub team. And then recommendations would be made by the community practitioners, and then the hub team, and a consensus would be made, and then they move on to the next one. At the very beginning or the very end of the session, there would be a didactic presentation about some facet of hepatitis C. And this was not an eye-glazing 60-minute, 86 chart didactic. This was a smart, punchy, 10 to 15-minute didactic filled with pearls. And so the idea was that he would create resources throughout New Mexico of educated primary care providers who were educated in hepatitis C, who could then provide a resource for others in their community so these patients wouldn't all have to go to New Mexico. And the other huge advantage here was that because these people connected with Sanjeev and his group in New Mexico through ECHO, they knew him and he knew them. And so they could just pick up the phone and call him rather than refer a patient and wait a year for the patient to be seen. And you can see intuitively, this is totally different from traditional telemedicine. So the whole objective of this then was to enhance self-efficacy among the primary care providers and allow them to start first-line treatment, co-manage patients with hepatitis C with academic teams. So Sanjeev did this for a few years. He got an NIH grant to ask the question, does this work? And obviously it worked because he published it in the New England Journal. Turns out that those patients cared for by those primary care providers who took the CME ECHO course and participated in ECHO, and they would come back again and again, not just one 10-week course, they'd come back again. Patients cared for in the community by these people did as well or better than those patients who were cared for by the experts in Albuquerque. Since then, ECHO has gone viral throughout the world. Ontario now has 28 ECHOs. So here was the situation in 2016. We had pretty much operationalized the whole provincial strategy with the district and regional centers that I've described to you. We created all the guidelines that you saw. We did everything we were asked to do, but we were complete failures in terms of getting an effective KT strategy for Ontario. And so in 2016, we were invited by the Ministry of Health to apply for funding for Project ECHO to address this issue of knowledge translation for epilepsy across the lifespan. And we put together a proposal, and it was funded in 2017. And what we proposed was something was very different at that time. what we proposed was a decentralized hub approach. Our idea was that we now have these 9 district and regional epilepsy centers across Ontario. So why not have each center, district or regional, be a separate hub? And then they could recruit their own community partners or spokes and develop their own teams, and everything would be, but it would still be one network with decentralized hubs. But the whole system will be run through Sick Kids. So the administrative hub would be Sick Kids in terms of the money flowing from us, the ministry, out to the hubs. In terms of the infrastructure that we would provide, the IT infrastructure, which is really critical, all of that would be provided through Sick Kids. And the idea was that we would deliver 2 curricula, one for epilepsy in children and youth, and one for epilepsy in adults. So the adult epilepsy, district epilepsy centers and regional centers would do the adult curricula, the pediatric district epilepsy centers and regional surgery centers would do the epilepsy in child and youth curriculum. And each hub had an interprofessional team, which was composed of the number of people that you can see there. This is our team at Sick Kids. We're very fortunate to have an extraordinarily talented group of participants in our hub. And the idea was that once all 9 hubs got up and running, we would stagger the cycles. And if you were a community partner and you missed, say, today's didactic at Sick Kids, then tomorrow you could sign up. You could call in to Rajesh or Kevin's Echo at McMaster, and you get the same didactic but a different case report. So the fundamental goals, really, there are 2 of them. One is it all has to do with best practice care for epilepsy and trying to enhance and deliver best practice care across the province, not only in unserved populations. And it's really important, the fundamental driving principle of this whole project, once again, has to do with understanding the indications for and providing access to epilepsy surgery. So this is where we are now in terms of our Project ECHO, epilepsy across the lifespan. We're in our 3rd cycle. We have 9 adult and pediatric hubs up and running across Ontario for 15-week cycles. 75% of our registrants are medical doctors, and the balance include the other kinds of people that you see there. And if anybody's interested in looking at us, then you can go to our website, which is a terrific website, thanks to Salma Hussein. We've done a lot. If you sign up for Project ECHO, if you get a Project ECHO, one of the reasons this works so beautifully is because Sanjeev and his group in the University of New Mexico have standardized it for everybody across the world who uses Project ECHO, uses the system that they use in New Mexico because it works. And one of the things they do in New Mexico is they constantly evaluate what we're doing. And so we constantly ask feedback from our community partners, and we look and try and determine learner satisfaction amongst this group. And it is off the scale, as you can see there. A really interesting reason to me that people gave for signing up for Project ECHO is they don't like to travel all over the place to get CME. But invariably, there's tremendous satisfaction amongst our learners at the completion of our Project ECHO cycle. So that's where we are now with Project ECHO. Where we're going is that we're currently thinking about expanding Project ECHO from community practitioners and adapting it for neurology trainees throughout Ontario. One of the things we've not done as much as I would like us to do is to develop proactive strategies to reach First Nations and northern communities in Ontario, and we really need to devise creative strategies to do that. And if anybody in this audience has any suggestions for this, I'd really like to hear it. And we've just begun to look at how we can answer a really critical question here. Are we making a difference on practice and outcomes for patients with epilepsy in Ontario. And Jorge Berneo in London is spearheading our efforts to design study in this regard. There's a really fascinating and wonderful advance we've just made in our Project Echo Epilepsy Across the Lifespan. It relates to the fact that in the last 5 years, there's been a virtual explosion of understanding the role of genetics in the etiology of epilepsy. And we've just added, expanded our curriculum to include epilepsy genetics. We now have a little satellite echo. We had a 5-week Project Echo Epilepsy Genetics course in October, which was heavily subscribed from across the province. And we're going to repeat it in February, and we've incorporated more and more epilepsy genetics into our main curriculum in both the adult and the pediatric curriculum. So, all teach, all learn is a mantra that Sanjeev talks about all the time, and I can tell you, having been, and Elizabeth, I'm sure, agrees with me, that I learn as much from our community partners in our weekly echoes as I hope they learn from me. It's just remarkable, the talent and dedication of each and every one of these people who sign up to participate in our echoes. It's really an inspiring experience. And so this is how we bridge the parallel universe between community and academic practice. And we've created this remarkable, unique in all the world, end-to-end epilepsy care in Ontario, which goes from basic care, first seizure, easily controlled epilepsy, to epilepsy surgery, to taking care of those patients, adults and children who have epilepsy that aren't candidates for surgery, and with a huge and important knowledge translation component. So this is the result of a really unique partnership. And the partnership, there are hundreds and hundreds of people involved in this, as you can see on the left-hand side of the column. But there are a few that I really needed to point out because they were integral to how, to us achieving what we did and getting where we are. Jim Bowen was the person, he was a scientist at McMaster who spearheaded the original study for PATH, who presented with me, he co-presented with me at OTAC, and every place we went, Health Quality Ontario, up and down the ministry, Jim was there presenting with me. Jorge Berneo is my adult epilepsy counterpart, and he's in London. Superb epileptologist, very well known, and I'm a pediatric epileptologist, and so in order for me to present a cohesive, coherent, incredible proposal for an epilepsy across the lifespan prevention strategy, I had to have an adult epilepsy partner, and Jorge was that person who were on the same page every step of the way, and he presented with me many times. Jim Rudka was invaluable, and once we got funded through Provincial Neurosurgery Ontario, Jim was invaluable in terms of helping provide the infrastructure. And Anastasia Vogt is the one person who contributed the most to this whole thing. She was the manager of the provincial strategy in terms of getting this operationalized from Critical Care Services Ontario. And then she helped a number of us write the ECHO proposal. Then I was lucky in recruiting her to Sick Kids, where she operationalized Project ECHO and ran it until she left on maternity leave last May. So there's one other reason, though, that this happened. I mean, if you look at the breadth and depth and enormity of what has happened in the last 10 years, you think, how could this happen in Ontario? Because it's never happened anyplace else in the world, I guarantee you. And I'm going to tell you why it happened. So we're going to go back to January 2011, a day not unlike today, cold, snowy, and a number of us, Jim Bowen and Irene Elliott and Liz Ferguson and I and Laurel Brown, went down to St. Mike's to present the MEG data at OTAC that I told you about. And we went through the whole presentation, and I had thought that at the end of our presentation, we would present a patient a patient in which MEG was important in terms of that patient's outcome. And so what I'm going to do is present to you the patient, the exact same presentation that I gave to them, because this is the presentation that galvanized OTAC to ask the question, how come so few patients get epilepsy surgery, and set us on the road. Every time I made a presentation, we presented this patient. And so everything I've talked about today, everything that we've accomplished, would never happen without Anthony. So Anthony is a 15-year-old boy with lifelong seizures, unresponsive to all medications. And the question is, he came to us, is he a candidate for epilepsy surgery? And this is the evaluation that we do. So his history was that he was having these sensory seizures, that is seizures. He would have numbness and tingling in his left hand. And then sometimes this would progress to jerking of the left hand. And then sometimes that would progress to a generalized convulsion, where he'd fall down and have a convulsion. So the sensory seizure, the numbness and tingling suggests, in the left hand, suggests that the seizure might be arising from the right parietal lobe, which observes sensation. And then the jerking suggests that the seizure moved anteriorly into the motor cortex to produce movement. And so that was the history that we got. He'd had seizures since he was 4 years old, so 11 years of seizures, failed multiple medications, was having seizures several times a week, would have a generalized convulsion once or twice a week, sometimes in school. Physical exam was normal. EEG showed abnormal electrical discharges on the right side. You recall what I said in EEG represents the field potential of electrical nerve cells in the brain, and a seizure is a paroxysmal discharge of electrical activity. Sorry. Video EEG captured the seizure that we talked about and said, yes, it's indeed coming from the right side. MRI was normal, which is kind of a bad sign. That indicates that there's no lesion you can take out to stop the seizures. Functional MRI is a way to look at language, and it was on the left-hand side, as it is in 95% of the people, which is good news because it looks like a seizure coming from the other side. Neuropsychology is extremely important in evaluating patients for epilepsy surgery, because sometimes neuropsychological deficits can point to the side the seizures are coming from, and where on that side the seizures might be arising from. But in Anthony, the neuropsychology was normal. He was depressed and anxious, as you might predict in an adolescent boy on multiple drugs, having seizures all the time. And the MEG, the reason we made this presentation, was abnormal. And the MEG showed abnormal magnetic activity in the right sensory cortex. And you recall that this indicates that there's abnormal electrical activity in the right sensory cortex, i.e. that's probably where the seizures are coming from. So this is Anthony's MEG. And just to orient you, this is his nose, back of his head is here, his ears would be here, and this is abnormal. These are MEG dipoles, which is abnormal magnetic activity. And this little spot here indicates this is where his sensory hand is. So in a way, this is the good news, is that we have an area that we can focus on where we think the seizures are coming from. The bad news is it looks like if his sensory hand is here, by definition, his motor hand is here. So if we went in and took out this area of brain, we would leave him with significant weakness of his left hand. And this is a sagittal view of the same thing. His eyes are here, back of his head is here, and this is where the abnormal activity is, and this is where the motor strip is for his hand. So at that time, we were doing subdural grid. That is, we placed electrodes on the surface of the brain, and we designed the subdural grid based on where the MEG, and this is the MEG abnormality, and this is the grid. And Dr. Rudka, we took Anthony to surgery, did a craniotomy, placed the grid. Each number is an electrode. This image was taken at the time of surgery. This is the front of the head, the back of the head, this ear is the top of the head. And this is Anthony's seizure, which I'm going to show you. Basically, this is the EEG. This is Anthony. This is the image that I showed you with EEG data embedded in it. And so all this glowing it means abnormal activity. So this is an epileptic brain, which is hyperactive electrical activity. The seizure is going to happen right here. You see this bright light? That's a blast of electrical activity coming out of the sensory areas here, motors here. And so, bam, seizure starts. He wakes up. He feels the sensation and numbness in his hand that he always feels. He tries to stop it because he knows what's coming. Now it's since the seizure discharge is moving anteriorly into the motor strip, and he's having jerking of his left hand. And now the seizure is moving to the other side of the brain, and he's having a generalized convulsion. So if you don't remember anything else from this talk, remember this image. This is epilepsy, just fire in the brain. So based on these data, Dr. Redick was able to go in and remove this part of the brain, which was the sensory hand, and spare the motor hands. And Anthony did not have a motor deficit. So he's now been seizure-free for 15 years. He drives, plays the guitar, and he's married with a new baby. And this is what he'd be like without surgery. He'd just be incapacitated and at risk for sudden unexpected death. Okay, we're winding up here. This is our operations group for our ECHO, Project ECHO, that's responsible for everything I told you about. So this is Anastasia Vogt. This was done, we had this meeting, this was her last meeting before she went on maternity leave. She now has a little girl. Elizabeth, you know, this is Jorge Berneo, who I've talked about, Linda Nguyen, who's our nurse educator, Tristan Moyert, who's our acting project director, Salma Hussein, who's our data manager, Kelly McMillan, who's our Learning Institute director, Zoriana Salo, who was acting project manager for a while, and Kirk Nyland from the Ontario Brain Institute. This was a guest I invited for our last ECHO with our last Zoom meeting with Anastasia. His name is Mambo. He lives on a farm in North Carolina. And the other person who I really need to acknowledge here is Pam Hoogley, who's been an untiring advocate for our Project ECHO with the executive and the hospital, and just has been superb support for us all around. Okay, so I'd like a final word, close with a final word to everybody in the audience, which is a little off subject, but I think it's important for me to say this in light of what we're going through with this pandemic. So this is for everybody who cares for and about children, and that's probably everybody in the audience. You wouldn't be sitting there in front of your screens. This wonderful image, which I really love, depicts the unbridled joy that each of our patients give us freely, in which we all try our best to reciprocate in kind to them and their families in these difficult times. Thank you so much for getting up this morning to listen to my stories. I'm happy to take any questions if we have time.
Carter, thank you. Well, it's been amazing to witness this transformation of our epilepsy program and our transition to ECHO. I've been lucky to ride on your coattails and be a part of it. I welcome people to put questions into the chat. We have one from Dr. Jim Recca. Great to see him joining today. How do you think advanced genetic testing and newly diagnosed genetic conditions, lesions, will affect workup and investigation of patients with non-lesional epilepsy?
So that's a really great question. I think that it's going to have an important impact on across the board. So if you look carefully at patients who have epilepsy, it's almost always a complex polygenic disorder. But if you look carefully and do an appropriate evidence-based genetic evaluation in patients with epilepsy, you can come up with an answer in up to 40% of patients. And that has a huge issue, both in terms of treatment, because some of these genes are actionable. And it also brings closure to families who are so desperate to find out what's going on. And it's hugely important, obviously, for family planning. And it's important, I talked a lot about epilepsy surgery, but it's important to understand that a genetic diagnosis of epilepsy does not exclude the possibility that in some patients who have genetic diagnoses, they still may be candidates for curative epilepsy surgery.
Thanks, Carter. I think it's one of that kind of highlights the need to transition the epilepsy strategy into ECHO to share that knowledge so that kids who are living with epilepsy, and as Jim described, a non-lesional epilepsy, to ensure they make it to an epilepsy center where they can get that kind of investigation to figure out how to transform our care. Jorge Berneo in London, one of our partners, has put in a nice comment, not a question, sorry, but thank you for that, Jorge. Stan Slotkin asks, are there challenges going forward in maintaining the funding for this important evidence-based program?
So that's a really good question. Thank you, Stan. So I think that there are challenges going forward because I mentioned earlier, I think we're kind of become the victims of our own success. There are challenges even before the pandemic, which has really been difficult for everybody. There are challenges in meeting the need for our increased numbers that are being referred to us in our epilepsy centers by virtue of Project ECHO and the numbers of patients who are candidates for epilepsy surgery. If this works, as I would really hope that it works in time, if you really want to get a truly comprehensive care program, we have to reach patients in the North, and we have to really make epilepsy surgery available to everybody who needs it. And that's going to require a considerable investment of resources in terms of surgery and neurology.
Thanks, Carter. I have two similar questions, one from Theo Mores and one from Jim Drake, asking really about whether we should or could adopt a similar approach to other conditions. So Jim says, could we adopt this approach for other conditions we manage at tertiary or quaternary care centers? And he's given examples like spasticity, movement disorders. And then Theo says, it seems that Project ECHO could lend itself to other conditions, such as even asthma, as an example. So what advice, how do you think we go about, I'm gonna kind of summarize, how do you think we go about applying this to other conditions? What advice can you give to get people to get our own echoes or other echoes going?
So Project ECHO can be used for anything. I mean, it's so beautiful the way it works. And I have to say that the Ministry of Health has been so visionary in funding Project ECHOs. The first one was in 2013. It was Andrea Ferlin and her colleagues, Ruth Dubin, developed the Project ECHO in pain. That was the first one in Ontario. There are now 28 in Ontario. And so the ministry is amenable to entertaining ideas. For example, I noticed when I was reviewing this, the number of Project ECHOs for my talk, that there are now 2 or 3 COVID Project ECHOs, which must have just been funded very quickly in the last few months. So virtually anything works. And the other beautiful thing about Project ECHO, there's a whole now, there's a super hub for Project ECHO in Ontario. And if anybody who's really interested, I would suggest that you contact either Kelly McMillan or our project manager, our program manager, Tristan Maynard, because they can direct you about to people in the super hub. Eva and super hub can direct you, give you guidance about how to apply for one. But the really interesting thing about Project ECHO is this amazing transparency. So when I started, I had no clue what Project ECHO was. No matter where I turned, whether it was CAMH for the mental health, or whether it was Andrea for the pain, or whether it was here for the pediatric echoes, which had just been started at that time, everybody just gave me everything. Here's our budget. Here's all the drafts of our proposal. Here's everything that you need. And it was invaluable. And everybody does that. And I would do that if anybody asked me. So all you have to do is contact either our program manager or the pediatric echo program manager or Kelly to get started.
Thanks, Carter. I would agree. You can use echo for anything, including probably non-medical things. You know, I think it's got very broad applications. Lots of positive comments in the chat. Don McGregor points out there's a very active pain echo. I know you and I are aware of that. Terry Broda is commenting on some of the challenges. She was a nurse practitioner that worked in the north for about 5 years, and most of the pediatric patients from Sioux Lookout actually went to Winnipeg. So acknowledging some of the challenges with the interprovincial relationship there, and wondering about creating connections up to Sioux Lookout as a way of optimizing care for kids with epilepsy up there. I don't know if you have
I would love to do that. Elizabeth knows, you know, we attract people at our echo from all over Canada. And just this last Monday, we had someone from Colombia in South America. So I think it'd be perfectly reasonable to, and we know people in Winnipeg, you know, it'd be perfectly reasonable to set up transprovincial echoes to try, and that might be an interesting strategy to help deliver better care to the far north.
Yeah, I agree. I should say that it turns out that question was not from Jim Drake, but from George Ibrahim, for some reason logged in as Jim Drake today. So just to clarify that. Karen Leslie asks, given the barriers to participation by practitioners in the north and more remote areas, is there any consideration of finding support for communities to get more reliable internet access? She notes, I recently read about this being provided through Elon Musk's space program. Because we recognize that limited internet access has a significant impact on access to care and learning at what sounds like a reasonable cost.
That's a really, really important question. I saw the same article about the Elon Musk program. Just a word about Sanjeev. Sanjeev pioneered Zoom. He worked with the Zoom people actually to develop Zoom for areas with very limited internet access. He's from India, and he's got an extensive Project Echo throughout that country, which delivers Echo to rural areas in India, which have very limited internet access. And again, once again, the University of New Mexico is a huge resource for all of us throughout the world who use Echo. So I think if we put that question to Sanjeev, he might be able to come up with some interesting ideas.
Arij Majoub, who's a trainee within our division, is asking, do you find that community neurologists or community pediatricians that were trained at larger centers have a better understanding of epilepsy surgery indications?
You know, I don't think so. I think one of the problems is epilepsy education and training programs everywhere. And again, this is not unique to Ontario. This is throughout the world. So the answer to the question, Arij, is no, I don't believe so.
I will direct people also that there's a comment in the chat from Alyssa Gumapak noting that there's a complex care echo at Sick Kids. And they've done, actually they want George to know they've done a topic on tone and spasticity. So echo is spreading like wildfire into neurology as well. Carter, there are lots of congratulations to you in the chat for an excellent presentation. Thank you again on behalf of all of us at Sick Kids and those that are listening beyond for all the work that you've done to promote epilepsy care in Ontario. And everybody stay safe and have a great day.
Thank you all.